First abstract, an oral presentation is going to be given by Dr. Alexandra Collis. Dr. Collis is at the University of Washington School of Medicine Transition to Residency course director. She's an assistant professor in the Division of General Internal Medicine and adjunct faculty in the Division of Healthcare Simulation Science at the University of Washington Medical Center. Dr. Collis's additional roles include serving as the core faculty for the internal medicine residency program and the director of medical internal medicine intern rapid response simulation curriculum. Dr. Collis has a special interest in using simulation to prepare for learners for rapid response and cardiac arrest event. Her talk today is on transition to residency, pre-rounding workshop, preparing students for effective and efficient EHR review on day one. Dr. Collis, the floor is yours.
Thank you so much for the introduction and for having me here today to talk about our workshop. Really looking forward to sharing this with you all. All right, so this is a workshop that we did for transition to residency over the last 2 years, a pre-rounding workshop, and this was done in conjunction with my team, Frank Chi, Nina Tika, Emily Lemire, Jason Lau, Paul Sutton, and Angad Singh, all my colleagues at University of Washington. And we have no conflicts of interest. So I want to start off with a little bit of background on the importance of pre-rounding proficiency. As you all know, many members of this group published a paper in Academic Medicine last year highlighting the critical topics that should be included in transition residency courses. And one of those was effective and efficient EHR use. And unfortunately, many of our courses don't include that because it's a really challenging thing to include. Nationally, there's a lot of gaps in proficiency. Many of our learners get a couple hours of training in EHR use, maybe a day at most. And a lot of what they're learning is passed down from other senior residents. So there's a lot of gaps in their ability to use the HR effectively and to pre-round effectively. There's a really interesting paper out of the University of Virginia where they looked at pediatric residents pre-rounding, and they looked at, how efficient they were and if they were completing the tasks needed, things like meds, orders, I's and O's. And most of them were not getting all of the tasks collected for these patients to have the information they needed on rounds. And particularly all of the interns they looked at was missing at least one piece of information for the patient. Similar at the University of Washington, we're seeing the same thing. Speaking to our program director leadership, we're seeing that our interns are running out of time, they're missing key data. And then there's been this really odd cultural shift that's occurred over the last 5 years since COVID. I'm curious to hear if this is happening at your institutions, but where our learners are not considering seeing the patient, talking to the patient, or doing a physical exam to be part of pre-rounding. So they're coming to rounds without having seen the patient. They're not able to really form a comprehensive assessment and plan without that key piece of information. So that's something we really wanted to try and reinforce with our workshop. So our workshop objectives was to develop a systematic approach to pre-rounding that our learners would apply in pre-rounding skills in time-compressed situations, knowing in medical school they might see 4 to 5 patients in 2 hours, but now they're going to be forced to see up to 10 patients, probably in an hour or so. And then we wanted them to identify and practice locating those key pieces of clinical data that were really important to certain diagnoses and that also might, be hard to find in the medical record. So we start off each session by focusing on how do you develop a systematic approach to pre-rounding. So really what we want them to come away with is have a system that you use every time. It doesn't have to be our system. You don't have to figure it out today, but have a system you use every time so that you don't miss those key pieces of information. And then also, again, be ready to change what you did in medical school. A lot of our learners were very successful in medical school pre-rounding, but this is going to be different. Time is going to be much more compressed. They're going to have more patients. They should be prepared to potentially change that. So we start off the session by showing them this really awesome video by Monica Jung, who's an internist out of UCLA. And it talks about an approach to pre-rounding, thinking about, how do you do that systematically? How do you develop a system? And then what are some of the common things in EPIC? Keeping in mind, EPIC is slightly different at every institution. And then the next part of our session is that we have a simulation. So we developed EPIC charts within the EPIC playground, and the goal is for students to practice pre-rounding. So we give them a couple handouts. We give them an overnight sign out, and then we give them a worksheet to collect data from the patient. And then once they've completed the simulations, we give them an answer sheet. And we have two patients during the session. The first patient, they get 15 minutes. The second patient, they get 10 minutes. And then I want to share kind of the patients that we have them pre-round on because we selected these patients specifically to reinforce some of those key pieces of information that are common, maybe specific to diagnoses, and then sometimes can be hard to find in the chart. So our first patient is a 54-year-old man with a CHF exacerbation, and the second patient is an 84-year-old man with an AKI on CKD and a fever overnight. And I'll walk you through what our handouts and worksheets look like to kind of simulate what it would be like to pre-round in the morning. So the handout is supposed to be the information that they would be getting in the morning. So you can see here we have a summary of the patient, just a one-liner. Next, they get night intern sign out and subjective. So this is simulate that experience of getting the information when they walk in the morning, synthesizing that night intern information, and then actually going to see the patient, collecting a subjective. And then over here on the workshop, you can see we have a subjective. And again, we really want to reinforce you have to see that patient to be able to feel prepared for rounds. Similarly, we provide them with a physical exam that they would collect if they went to see the patient in the morning, and we have a spot for the physical exam here on the worksheet. And then I want to give you just a brief overview of what the playground environments look like. So we created these patients to be intentionally complex, so they look realistic, to simulate the complexity that you would get trying to find information in a chart that's saturated with lots of other things. So here you can see the vitals are available for this patient. If you went to go in notes, both patients have an HPI or H&P. They also have nursing notes in there that have information that some of it may not be accurate to what's actually ordered in the chart, which is very realistic. We have results that you can look through in the results tab, both results from this admission and prior admissions or prior outpatient data. You can also see that under chart review, the way you would in a real patient chart. And then we have other pieces of data, EKGs, echoes, microdata, things both from this admission and then from prior admissions as you would in a real patient. So after we give them that 15 or 10 minutes to go through, collect information, fill out their pre-rounding sheet, then we do a debrief and we give them an answer key. And I'll just go through some of the things that we have included in this answer key to show you some of those key pieces of data we really want to reinforce. So a common one, our first patient is a CHF exacerbation. It's very important to think about I's and O's and weights. And sometimes those can be hard to find. So for this patient, included in the answer sheet is those ins and outs and weights. Next, we have the physical exam. So for this first patient, if they were to do the physical exam in the morning, they would note that the patient had 3+ pitting edema to the lower extremities, which is unchanged from yesterday. And without seeing that patient, they wouldn't know that key piece of information. They wouldn't be able to form, really a comprehensive assessment and plan. So again, just reinforcing that that is a very important part of pre-rounding. Next, for any patient that has diabetes or is getting their glucose checked, it's really important to look at glucose trends and insulin needs. So for this patient, if they look through the chart, they'll see that the patient was hyperglycemic overnight. And then if they actually look in the MAR, they'll see that the patient got 8 units total of sliding scale insulin yesterday, a piece of information that's going to be really important when deciding what are we going to do with insulin for the next day. Similarly, we really want to reinforce checking the orders and checking the MAR. So for this patient, they got 60 milligrams of IV Lasix yesterday. They refused it at midnight, which they would see if they looked in the MAR. And then it's actually not ordered, even though the H&P says that it is. So again, this they would notice it's not ordered and that they're going to need to order it. And then lastly, I think something probably a lot of us are reinforcing with our learners all the time is those checklist items, the importance of that and the importance of confirming that things are actually ordered. So for this patient, the H&P says that they're on sub-Q heparin, but then if you actually look in the orders, nothing's ordered. So that's a really important thing that we want them to key into. And then for the second patient, I'll just go through one more thing. We have a lot of overlap with the things that we want them to look up. But for the second patient, it was basically a patient with an AKI, developed a fever overnight. When they get sign out from the intern, they're told that the UA is not back yet, it's pending. But if they actually go and look in the labs, they'll see the UA is back, it's consistent with the UTI. And then if they look at microdata, they'll see that there's past microdata showing ESBL E. coli. So without actually checking that past microdata, they would not be able to adequately decide what to do for treatment for the patient. So again, we're just really trying to reinforce these are the specific things you want to make sure you take a look at in the chart within that abbreviated period of time that you have in the morning with the patient. And then after we do those 2 simulations, we have a quick PowerPoint slide with some EPIC tips and tricks, keeping in mind EPIC is different at every institution. So we really want to focus on things that would be helpful to them anywhere that they would go. So things like thinking about patient lists. What are they? How can you potentially customize them where you are? Summary tabs, etc. So overall, we got really good feedback. We did this in 2024 and then this past year in 2025, and we had our learners complete a survey in 2025. 17 of them completed a survey. I think we had about 35 in the whole course where the surveys were optional. They noted increased confidence in pre-rounding and being able to pre-round on a patient in under 15 minutes, and increased confidence in knowing what pieces of information that they would need for rounds. And then all of them felt that this was relevant to their upcoming responsibilities as an intern. And then I wanted to share a couple quotes, both positive and some constructive feedback that I think could be really helpful for us for refining our course and potentially for doing this at other institutions. So one learner said, appreciate the exercise in Epic Playground, especially the encouragement to finish the exercise under a realistic time pressure. Another said, I feel like pre-rounding is disorganized for me, so this was really helpful. And then a couple constructive feedbacks that we got. One learner said would have appreciated more tips on how to compile this information onto a paper for rounds. So thinking about those intern skills of being efficient and organized. And then another said, I was expecting to learn about how to pre-round on a patient in like 5 minutes. So, we thought 15, 10 minutes was really pushing them, but some learners, maybe a surgeon in the morning, seeing a bunch of patients and having to get to the OR, 5 minutes may be much more realistic. So that was really eye-opening to us. So overall, future work, this was kind of still a pilot session. We selected patients and key pieces of information that we found that our learners tend to miss. But I think, really this serves as a proof of concept and framework for how to practice pre-rounding. And next steps would be to take this framework and think about specific needs. So are there program identified performance gaps that we can use within this framework to teach those skills? Are there different time compression intensities? Are there different specialty specific tracks? I'm sure what a surgeon has to look for in the morning, what a pediatrician has to look for in the morning is very different. And perhaps that may also play into how much time is realistic for each of the groups to see the patients. And then, we chose Epic because it's a commonly available EHR system that many hospital systems use. But I think, this framework could be applied to other groups that might use it for things like Cerner or other EHR systems. And I think, overall, I would love to, this is the end of the presentation. I would love to hear any feedback, thoughts you have, anything you're similarly doing in your institution. And I would love to hear if there's anyone that would be interested in collaborating on something like this at their institution. We are teaching, we tried to stray away from having this very UW specific, knowing our learners are going to go out all over. But I think working with another institution where we do have those balanced viewpoints could really enrich what we create through this. And those are my references. Any questions?
Thank you very much, Dr. Collis. And participants, feel free to unmute and ask questions. I think we did have a couple of comments in the chat, just kind of talking about, the surprising aspect of how some of your learners did not see patients or did not think it was necessary to see the patients before rounds. Certainly seems to be a little bit of a shift. We do have one question from Dr. Levine about Epic Playground. I think kind of logistically, sounds like there's some difficulty getting access to Epic Playground. Was that an issue for you? And maybe by an extension, if one does not have access to Epic Playground, how might you approach this particular issue?
That's a great question. To be honest, I'm not sure. We did have access. The other members of my team are the ones that are very, very proficient on building this out. This is actually kind of outside my area of expertise. But if you email me, I could connect you with the person that is the expert in our group that could answer that question for you. I'm not sure though.
Thank you. Now, sort of an extension to that, at even at my own institution, we did have Epic Playground, but they lack the complexity that is required for this session to be really effective. So, in terms of building that, do you have a sense of how much your colleague spent to build that patient?
Yeah, sure. So basically what we did, the current patients, like you said, absolutely did not have enough information. They didn't have the tailored information we wanted. Most of them also just didn't feel realistic because they didn't have enough information. We looked into were there some patients we in the kind of Epic Playground system that we could borrow, but it didn't fit our needs. So we built them from scratch. I basically what I did was I just gave her a list of all of the data that I want in the chart. I wrote out the H&Ps, I wrote out the nursing notes, and then sent that over, and she kind of put that in the chart. I took a look at it and gave feedback. It sounds complex, but it actually wasn't that hard because I think I screenshotted a couple like live patients that I had, just the data to show her what it looked like and what were some of the things I wanted to see in there. I also think, maybe with ChatGPT, you could go ahead and like synthesize some notes or data that you would want that would make it just look a little bit more realistic.
Fantastic. Couple of quick questions. Did the students use all 10 or 15 minutes to pre-run on each of these patients? And then did you grade these exercises, or was it just formative?
It was just formative. I think it'd be really valuable to grade it. I presented this to a group of folks from my institution. They actually thought it'd be a good idea to have them hand in the pre-rounding worksheet and actually mark that up because it's a great way to do it rather than just having them recited back out. And then, it was interesting. Some of them did really well within the 15 minutes and actually thought it was too easy, and other ones struggled a little bit. So it was a big curve. I think a lot of that has to do with the lag in fourth year medical school and also maybe some of the specialties they're going into. So I think specialty specific tracks would be really valuable.
Fantastic. Any other questions from the audience? It sounds like there's a lot of interest getting into Epic Playground, and I think yeah, certainly I think we can all learn from each other in this community. Okay. Thank you so much for all your fantastic work, Dr. Collis, and certainly I'm sure there are going to be folks that are excited to collaborate with you.